Right, give me just a moment. I'm gonna do up our public call. Over here.
Oh, it's still not. Just like people are talking.
And then
Maybe that. Sure. No, sure. Sure. To leave right now, but I truly don't know what to do because I have my sound off and my mic off.
okay, our call is live. So committee member Anderson, we will turn it back to you to bring us back into open session.
All right, it looks like we need a motion to do that. So do I have a motion to move to resume the open session at 10:47 a.m.?
So moved. Committee
Great, do I have
member
a second?
Gibler.
Seconded, committee member Wickenhagen.
Great. And committee member Anderson, I agree. About committee member Gibler,
Aye.
committee member Hammond,
Agree.
committee member Myers,
Agreed.
and committee member Wickenhagen.
Agree.
All right, this motion passes. And looks like we will now receive a rules update from staff member Davis.
That is PowerPoint.
This PowerPoint. Okay, give me just a moment. She has some slides to share. Just a second. Right, and can everyone see that slide deck?
Okay, let's give you a little rules update here. So, sorry, I'm getting my stuff ready and it's not doing anything that I'm asking it to do right now on my computer. Okay. So what I wanted to talk to the committee about was just a recent rulemaking, an item that's a rulemaking. So if you go to the next slide. During the last board meeting held in April, the board motioned to repeal the pseudoephedrine protocol, and I'm going to go into why that occurred on following slides. So this item is out for public comment. The rulemaking hearing, I have the time and date at the top, and if you go to our website, you get all the links and how to sign up if you would like to make public comment on it. Go to the next slide. So I did a little history. This was really fun. You know, I got to do a little research. So we have had the pseudoephedrine protocol for a long time. And this is kind of how it came to be. So back in June of 2005, on one of the statutes in ORS 475, which is our controlled substances chapter, .973 was amended to require pseudoephedrine to be in Schedule 3. And if you think back to that time, 20 years ago, this is when the methamphetamine crisis was kind of getting really going. And there was a lot of legislation happening around pseudoephedrine and precursors to methamphetamine. So that statute was required the board to schedule pseudoephedrine in Schedule 3. So in June of 2007, the board adopted pseudoephedrine as a Schedule III controlled substance pursuant to the legislation that had passed in 2005. In February 2018, which was one of the first meetings of this committee, the pseudoephedrine protocol was recommended by the committee to the board. And then in October, the board adopted the pseudoephedrine protocol by rule. Then 2.5 years later, in February 2021, the committee does a biennial review of all protocols. And so an update was made to the pseudoephedrine protocol to standardize elements of it with all the other protocols. It wasn't like significant like changes, but it was like trying to make the language similar. So using things like rolling 12-month period or just getting certain phrases to be similar across protocols. The board adopted those revisions to the pseudoephedrine protocol in June of 2021. And so that's the version that you see on the board's website. When you look at the protocol list, it'll say version 6, 2021. Then in September 2021, the PFAC had a discussion about retaining the pseudoephedrine protocol since a new bill that had passed in 2021, House Bill 2648, now allowed a transfer of pseudoephedrine to a person who is equal to or greater than 18 years old. And at the time, the PFAC decided to retain the protocol. It was maybe too soon. It hadn't been fully implemented with when it would say transfer of pseudoephedrine to a person in like real pharmacy terms, that means selling it from behind the counter using the federal database to record the transactions. So then in December 2021, the board actually adopted rules to move pseudoephedrine from Schedule 3 to Schedule 5, which they are permitted to do in ORS 475973, as long as they can, I'll show you the language in a minute, but as long as they can say that it won't affect methamphetamine rates within the state. In February 2023, again, the PFAC did their biennial review of all the protocols, and there were no changes made to the pseudoephedrine protocol at that time. And then now in May, really April, the board sent the pseudoephedrine protocol to rulemaking for repeal. So how did we get here? Next slide. Well, ORS 475005 says a controlled substance means a drug or its immediate precursor that's classified as Schedules 1 through 5 under the Federal Controlled Substances Act, as modified under ORS 475.035. So let's look at 035. Next slide. So here, this is the board's authority. Whenever the board determines a change or addition to the schedule of controlled substances is justified, the board, by rule, may order the change and fix the effective date. So the board has the authority to schedule non-controlled substances as controlled substances. They're also required to, in this case, by another piece of legislation. Next slide. So here's ORS 475973, which says the State Board of Pharmacy may not adopt rules that exempt a product containing ephedrine or pseudoephedrine from classification as a controlled substance. And then it goes on to talk about like the Schedule 3 classification may be modified by the board if the Board of Pharmacy finds restrictions on products containing pseudoephedrine under Schedule 3 designation do not significantly reduce the number of methamphetamine laboratories in the state. And the board was provided with information prior to making the schedule change to move it to Schedule 5 about how many methamphetamine laboratories we've had in our state in the past few years versus what we had back in 2005, 6, 7, as the crisis was growing. Next slide. So then we have to come back to, okay, pseudoephedrine is a controlled substance. We're required to keep it a controlled substance. And then we have to look at who can prescribe a controlled substance. So ORS 475 again, .005 defines a practitioner. And it's a physician, a dentist, a veterinarian, a licensed nurse practitioner, lots and lots of people. But at the very end, it says, but does not include a pharmacist or pharmacy. Next slide. Here's the statute about who can prescribe. So ORS 475185 says, except when dispensed directly by a practitioner to an ultimate user, a controlled substance in Schedule 5 that is a prescription drug may not be dispensed without written, oral, or electronically transmitted prescription of a practitioner. So think about the definition of practitioner says that's not a pharmacy or a pharmacist. pseudoephedrine's a Schedule 5, and as part of the controlled substances. So that's how we get here. So all this being said, is that the last slide there? Oh, yeah, that's the last slide. All this being said is that the board was provided the same information at the April board meeting and has motioned to send to repeal the pseudoephedrine protocol, as we now find that it conflicts with the laws in ORS 475. Any questions? Okay. We're not doing that now.
Okay.
Yeah,
Nice.
yeah. That's about a different subject.
Okay.
All right, so now we will move back to Miranda. That's the update on rules. Okay, Lauren, if you want to go ahead with the first mailing coronavirus vaccine protocol.
Sorry, looks like I was on mute. Close my tab and then, okay, here we go. All right. Now it looks like we are moving on to a formulary and protocol review for the coronavirus 2019. Is that something I turn back over to you, Staff Member Davis?
Sure.
To take over?
Sure. We have on the line one of our subject matter experts, Crystal Sharp, who is going to go over the proposed changes to this protocol. We're going to just keep seeing this protocol, I think, at every formulary meeting, because as you know, coronavirus vaccines change, the formulation changes, lots of things happen with this protocol. So I'm going to hand it over to you, Crystal.
All right. Good morning, everyone. Thanks for having me back to talk about COVID once again. I know most of us were here last time we talked about the protocol. There have been a few minor edits, and then a lot of that information has been input into tables for easier use. So I will go through that. But if we're starting at the top here, the header, just try to make everything alphabetical. So that was the purpose of that change to putting Pfizer BioNTech last. And then as we get into section 1, what's new, CDC lists Pfizer as Pfizer-BioNTech. So just trying to be synonymous with CDC. So you'll see that throughout the document. And then section 1, subsection B is just a grammatical change. And if we could keep going. So section 2, immunization protocol. This protocol is really identifying and making recommendations based on patient's age, previous vaccination status, and level of immunocompetency. If we could make an edit to this sentence just to make it a little bit more synonymous with the formatting, I would like to propose to change this to COVID-19 vaccine based on level of immunocompetency, then age, and then lastly, previous vaccination status, because that's the order of how we have our information organized. Thank you. And then we did remove the section that says according to ACIP recommendations in the vaccine package insert. And I think this just gave the public a little uncertainty as to if they could simply go off ACIP's recommendations versus following exactly what was in this protocol. So we wanted to eliminate any confusion, and that is why that was removed. And then I think the last thing was just a grammatical change. So that's all I had for section 2. Okay. So section 3, this is where you likely saw a lot of the changes. So I think the first protocol we had come out with was a little confusing. So the tables will hopefully help folks determine what people are due for next. But essentially, this kind of mirrors the pneumonia protocol, if you recall that. So Section A is a vaccine schedule for immunocompetent individuals. So that's really anyone who does not have an immunocompromising condition. And then under this section, there are 3 different categories. So first one we have is Table 1A. So these are patients 6 months through 4 years who are immunocompetent. And then we still have the caveat of the PrEP Act. So really just letting people know that the PrEP Act, specifically the 11th Amendment, allows pharmacists to administer COVID-19 vaccines to those ages 3 through 18. That protection does expire at the end of 2024, but really pharmacists are only permitted to vaccinate for 7 and up per the ORS listed. So we felt strongly about keeping that. And then if we could just keep scrolling down. So I'm not going to walk through all of the tables unless if someone from the committee has a strong desire for me to do that. But these tables are literally just taken from the CDC. So nothing altered, but just reformatted into our document, but completely identical to what they have. And then we have some just table definitions, again, same as what CDC has. So defining what an original COVID-19 vaccine is. And then CDC does recommend for the specific age group of 6 months through 4 years to receive a homologous vaccine. But there are some situations where they identify this may not be possible. So that information has been included as well. Okay. And then we're still in that immunocompetent group, but now we've moved on to ages 5 through 11. So again, we do have that PrEP Act caveat, same thing as above. And if we can keep scrolling down. There's some information here for children who transition from age 4 to 5 and how they should be completing their COVID-19 series. I'll pause. It looks like Andrew has a question.
Yeah, Crystal, committee member Gibler, can you, again, when micrograms is abbreviated, just use MCG instead of the UG.
Thank you.
I know you did a great job on all the tables, and I appreciate that. But I did notice that one spot there. Thank you.
Thank you.
I guess there's more, but anyway, if we can change those to MCG, that'd be great.
Okay. Thank you. I love that function. Thank you. Okay. And then as we progress down, so table 1C, this is probably where a majority of our patients are going to fall, is just 12 and up for immunocompetent individuals. And then there is, CDC has this caveat underneath the table. So I basically, again, just took what they had, but included the recommendation for 65 years and older where they should be receiving that additional dose of the updated 2023-2024. I think inserting this into the table is just, it gets really messy. So I wanted to keep it synonymous with what CDC has. And I think it is explained pretty directly in this fashion. All right, and then if we can keep scrolling down, next section. So this is where we get into our immunocompromised patients. So again, we have 3 sections here. We have age 6 months through 4 years with moderate to severely immunocompromising conditions. And if we could keep scrolling down. Okay. If we could keep scrolling down, this is just more information about how they continue the series if they go from 4 to 5. And then we have children ages 5 through 11 with moderate to severely immunocompromising conditions. And then lastly, we have folks 12 and up with moderate to severely immunocompromising conditions. One thing that I will pose to the group as if we want to discuss, but in a further down section in section 5, the list of immunocompromising conditions is thoroughly spelled out. I don't know if we want to have a reference at the table section where it says see section 5 for list of immunocompromising conditions, but that would be the only other edit I would propose for that section.
This is Committee Member Wickenhagen. I think that's a nice place to put the reference.
Okay, so yeah, this is our list, but I do acknowledge it's not up there. So if we could put in parentheses, see section 5 for a list of immunocompromising conditions or something similar to that. And then that would probably need to go under table 2A, 2B, and 2C.
Committee Member Wickenhagen, can I ask another question? Is it ever possible to maybe just like hyperlink these in these documents?
Staff Member Davis, so we have an issue with standards adopted by reference. If you do a hyperlink, then the link may be updated beyond the time when you reviewed it and the board reviewed it. And so that's why we have to have the information in the protocol, because you're adopting the outside standard as reference.
Fair enough. Thanks, Jen.
Yeah. So Crystal, what did you say? Where do I need to put this? To A, B, and C?
Yes, please.
Done.
Thank you. All right, so I think that's it for the tables. And again, that was the bulk of the information. So you'll see a lot of that text was removed. Again, that was just inserted into the tables.
All the old tables. Okay.
Okay, section 4, nothing new here, just updating Pfizer to Pfizer BioNTech. And then recommendations for use. So none of this material is new. The wording of the material is just synonymous with exactly what CDC has published on its website and is essentially just a repetition of the tables in text format. And then again, it follows the immunocompetent and then based on age and then immunocompromised and then the specific age categories. Okay, no substantial changes to contraindications. Again, just updating Pfizer's name. No substantial changes here, except we change patients to individuals. No substantial changes to section 9. Section 10, there was a miss on our previous protocol. So the expiration date for, I believe, Pfizer, the glass syringe is until the printed expiration date, not 6 months. So that was updated. And actually, can we scroll back up? Sorry, I'm jumping all over. There was one thing I think we forgot to call out that I wanted to just inform everyone of.
What section?
Section, the immunocompromised table, section 2A, 2B, 2C. So CDC does have some pretty vague recommendations on individuals with immunocompromising conditions and their ability to receive subsequent COVID-19 vaccines. And basically what they recommend is that those folks with immunocompromising conditions are able to receive additional doses based on a healthcare provider's discretion. On our previous protocol, we did have that, but given that these protocols are not able to have judgment, so I'm trying to find where that was called out. We just indicated that any further doses, aside from what's listed in the table, need to have a prescription to be provided. Yeah, it's actually in this section here. So that removes any level of vagueness for our pharmacists. So that was the last big change that we had, but I'm open to any questions, suggestions, or anything from the group.
This is Committee Member Wickenhagen. Just a comment. This looks like a lot of work. Thank you.
You're welcome.
Agreed. Thank you for being willing to work on these so much. This is Committee Member Anderson.
This committee member Gibler, thank you as well. Just some, I guess I have a grammatical question. I'm not an English major, so I do not understand, but when you keep the phrase moderate or severely immunocompromising is moderate to severely, should it be moderate to severe or should it be moderately to severely? But one is, and I don't know what the term is, but there's just, it's inconsistent. So it would be moderately or it'd be severe. I think change one to the other.
Thank you for pointing that out. Yes, it should be. I'm looking at CDC and how they have it, and I agree with you. Yeah, so moderately or severely, if we could adjust that to make it correct.
Just an editorial. Sorry, it's not substantive, but I don't know why I noticed
need
those
someone
things.
looking at grammar. Thank you.
MCG, whatever. My contributions are pretty small.
Just keep popping up. I think I'm done, and I'm not. I feel like I can get these done pretty quickly, so I want to just go ahead and do them.
You're very fast. Thank you.
Thank you. Find and replace. Okay, I think we've circled around. Okay, we're good. All right. Back to you, Committee Chair Anderson.
Thanks, this is Committee Member Anderson. Are there any other discussion points that anyone on the committee would like to make on this protocol?
Oh.
All right. Do I have then a motion to move to recommend the coronavirus 2019 vaccines statewide drug therapy management protocol version 5 of 2024 as revised today to the Oregon Board of Pharmacy for review?
Myers, so moved.
Thank you. Do I have a second?
Committee member Gibler, second.
Great. This Committee Member Anderson, I approve. Committee Member Gibler.
Aye.
Committee Member Hammond.
I approve.
Committee Member Myers.
Aye.
And Committee Member Wickenhagen.
Approved. Aye.
Great. This motion passes. Looks like the next item on our agenda is to look over the continuation of therapy protocol. Let's see, does that just get turned over back to you guys?
Yes, sorry,
And
back to
thank-
staff member
Thank you,
Davis.
Crystal.
Yes, thank you, Crystal.
All right. So we saw this at our last meeting. We made some modifications around the wording for damaged prescription therapy. And now you're seeing this protocol again as a result of 2024 House Bill 4002. One of the sections in it permits a pharmacist to prescribe and dispense early refills of medication for the treatment of opioid use disorder. So we've been using this protocol, continuation of therapy. You can do a lot of different things. We had added in the emergency refills of insulin after that bill was passed with the same with parameters, and then now adding the parameters for early refills of opioid use disorder medications. Let me turn off the formatting comments because those are really not helpful to anybody. So you can see I've just added this up here and then added the sentence about this. And once we get a law number, which will probably be 1 to 2 years, we'll put the correct law number in there, but for now. And then this section here, so we've always said any non-controlled drug or device to a person who has evidence of a previous prescription drug or device from a licensed healthcare provider in order to, and this was the damaged conversation we had, to replace a damaged prescription. And now I've added in language from the bill for the most part. A pharmacist could prescribe any non-controlled drug or device with evidence of a previous prescription drug or device to do an early refill of a non-controlled drug or device to a person who has evidence of a previous prescription for opioid use disorder from a licensed healthcare provider in order to replace a medication that has been lost, stolen, or destroyed. And then we're going to talk about this time period. And then with refill a medication for which the previous prescription expired in the prior 12-month period. And I have the language over here from the bill. So this is just modeling the same language as in the bill that says an early refill means up to 3 refills of a current prescription for a medication that has been lost or that has been stolen or destroyed. So you have lost, stolen, or destroyed here. And then 1 refill in a 12-month period of a medication for which the previous prescription expired in the prior 12-month period. So that's an exact replica. The question I have for the committee is, should there be a time period qualifier in the first sentence? There's one in the second, because that comes straight from the bill. Non-controlled prescription is only valid for 1 year per our rules, 855-041-1125. And so should the pharmacist have the ability to replace a medication that has been lost, stolen, or destroyed that's non-controlled for opioid use disorder up to 3 times, which we have the parameters later in here, but should there be a time period, something to discuss? And I actually have this conversation a second time, so I'm gonna just finish going through the piece of the protocol and we'll talk about it again. I had to update the standardized patient assessment process elements because the bill does require that the pharmacist who does this early refill notify the patient's primary care provider and licensed healthcare provider who made the previous prescription of their dispensing of early refills to the extent permitted by state and federal law. Currently in this protocol, notifying the provider was optional. And so I just left this optional for insulin, non-insulin, and non-opioid use disorder medications, but required for opioid use disorder medications. And the committee, you obviously have a choice if you wanted to make it required for everybody. I was just trying to do what we had to do minimally to meet the requirements of the bill. Under prescribing parameters, added for non-insulin and non-opioid use disorder medication, that these are the limits that you put in place. And then for insulin-related devices and supplies, no changes. And this is congruent with the law about emergency insulin. And then this would be the new section for opioid use disorder medication, excluding controlled substances, a quantity consistent with the amount specified in the most recent prescription for the medication. The maximum quantity is the amount specified in the most recent prescription for the medication. The maximum frequency is no more than 3 refills, and that comes from the bill. within, and this is that 12-month period that I want to discuss with you, or the prescription expired in the prior 12-month period, no more than one refill in a 12-month period, in accordance with federal law, since that's in the bill as well. So back to you, Committee Member Anderson, to discuss, and I specifically need feedback on if you want to put a time limit duration of how often, can the pharmacist give 3 refills in a 6-month period, in a 20-month period? Like, what's there? There's just no information in the bill.
This is Committee Member Anderson. Is there, so if the bill doesn't really state anything along like the frequency and that sort of thing, I'm wondering if we couldn't just keep it consistent with the others, the other pieces of this particular protocol.
Member Davis, yes, like that's an option, just to stay silent on it. It's just kind of remembering that like this could be a situation where a patient comes in on Monday, you replace their lost prescription. They come in on Tuesday, you replace their lost prescription. They come in on Wednesday. Like, did you want any additional buffers or boundaries, or did you just want to leave it the same as the legislative, what was in the bill? The bill does restrict it if it expired in the last 12 months to only 1 refill, but if it's not an expired prescription, you can give up to 3 refills.
I mean, this is Committee Member Gibler. I would submit that we just keep it consistent for simplicity's sake. Nobody, like, we've got, as far as I know, it's only oral naltrexone is all that, and no one's going to be refilling it frequently.
Yeah.
Keep, several dollars per pill. So nobody's going to be paying cash. Insurance won't pay for it if it's refilled too soon, too often. So it's just, I just don't see it happening in real world.
I have sort of a, I guess maybe a sorry, this is Committee Member Anderson. Maybe sort of a clarifying question, since these are not going to, I agree with Andrew, there's like really just one medication that this potentially applies to. Do we need to say something about the non-controlled? Yeah, oh, we do have that. But I guess my other point is that, like, where is the difference between that and the other pieces of non-insulin? Because it used to theoretically would have fallen under that.
Correct. Yeah. So Staff Member Davis, here's the non-insulin. Your maximum quantity can't exceed the original duration of therapy. It can't exceed a 60-day supply, which is really usually 2 refills. Damage, no more than 1 replacement, a rolling 12-month period, or extending therapy, no more than 2 extensions, a rolling 12-month period. This has to be called out separately because it has different restrictions in the law. If the law hadn't been so specific, we could have just kept it under the general non-insulin and include opioid use disorder medication. But the law has very specific things that conflict with the committee's recommendations previously.
So for naltrexone, if when you say no more than 3 refills, could that be no more than 3 90-day supplies? So up to 3/4 of a year could be early refilled, as it's written now.
It says refill means a supply of a medication consistent with the amount specified in the most recent prescription. So if the most recent prescription was 90 days,
Right.
that seems that could occur.
Thank you.
This is Committee Member Anderson again. So from what I've gathered on this particular protocol, it's been revised twice to include other pieces of statute that passed to include the insulin and now opioid use disorder medication, which is really just oral naltrexone. So my question has to do with the original protocol that this committee passed ages and ages ago that had original recommendations for how many times you could extend it and for duration of therapy and things like that. Is there any thought from maybe other committee members about, because I would think that this committee could adjust those recommendations to maybe help make it less confusing, because it's starting to get really confusing, I feel.
Yes, you have the authority to change the prescribing parameters for the first bullet, because there's no like conflicting law per se that requires more restrictions. The committee has discussed this. I know in 2021, when we did the review, there was a discussion about whether we wanted to change anything. And at the time we were told no, but given new laws and new information, that was something that was, that's something you can contemplate. The other thing I would say is we could pull these into 3 separate protocols. And that's something I can do. And then all the other documents that go with it, page 2, 3, 4, 5, 6 would just be exact copies. I just wonder, I know it's confusing because now we have all these laws that say different things. If having it in 3 separate protocols might lead someone to open like this non-insulin, non-opioid use disorder medication and somehow prescribe something incorrectly. So that's also something you could consider as having me split it out into 3 separate protocols.
No, this is Committee Member Gibler. I think just keeping it in one document would be easier for pharmacists.
So then
But I don't know. Maybe others have ideas if that would actually be easier or not.
This is Committee Member Anderson, can I kind of go back to when we added emergency insulin to this? So emergency insulin had its own piece of statute, right? That the pharmacist could prescribe this. Did that get updated to specifically ask the PFAC committee to include it in one of the protocols on the compendia? Or did we just decide to do that like we did with contraception?
the committee was asked if you would be open to including insulin and insulin related devices. At the time, the direction that I had received from the board was related to making this easier for pharmacists and having all prescribing kind of in one place rather than having one in rule and one on protocol and one here, because we had contraception separate too. It was its own protocol process. And for consistency and making everything get biennially reviewed and making sure that, the process is just behind keeping these updated, it was brought into this protocol. And the committee did discuss that at the time. And we moved forward with that direction, and the board motioned to send it to rulemaking and then adopted it.
Okay, yeah, I guess I'm just trying to figure out how to make this less confusing. Do others on the committee have any thoughts on what might help? Do others like it broken down like this with all these completely different requirements for how much and how often?
I don't have any ideas. This is Committee Member Gibler. I would approve it as written, but I don't have any ideas to make it more clear either.
Thanks, Committee Member Kipler. Anybody else? Do others think this is, so Committee Member Gibler said he was fine with it. Are other people okay with how it's written?
Yes, this is committee member Hammond. I'm okay with how it's written.
What does the committee think about, this committee member Gibler, about the refills, language around refills versus day supply? Do we permit 3 refills or 3 30-day supplies or 3 90-day, whatever the original prescription was written for will determine how much is refilled. I'm just not, if there is a possibility of refilling 9 months out of 12 months, and I just think I don't think that situation would ever happen. I just think that if it is happening, there probably the patient needs some guidance, and probably support from someone other than their pharmacist.
This is committee member Anderson. I totally get what you mean. Because truthfully, I think this bill originally was meant for buprenorphine and not naltrexone, but because it didn't call anything out specifically and because it has to exclude controlled substances, then we're kind of stuck with this idea of naltrexone, which
Right.
then at that moment could start including a 90-day supply as opposed to what was likely the case of 30 days previously when they wrote the bill. So I agree. I don't know what to do about that. I kind of like the idea of maybe just leaving it with what the language in the statute that passed says.
This is committee member Wickenhagen. Can you hear me?
Yep.
Yeah.
Okay, I think I inadvertently muted myself for a second.
Oh, sorry.
I it's difficult when you use exactly the words from statute. Well, the information I've been given is you use exactly what it says in statute or you don't. But if you have sort of elements of what's in statute, that's kind of problematic because you have to make sure that that's consistently updated. So that's just a thought I'm going to put out there. But also, I don't have a great idea to make this simplified. And I think we should probably leave it as is, because it already is complicated. And the more we sort of fiddle with it, I think we could potentially make it worse, but open to other thoughts.
This is committee member Gibler. I agree with you. That probably is the best way to approach this. And the reality is we probably won't see any prescriptions for naltrexone. So we just keep it simple and let's move on. But as it's written, it's safe for patients, so, and it fulfills the need of the statute.
This is Staff Member Davis. I guess I just need clear instruction maybe from the group. Are we removing the 12-month period and the first bullet? Or are we keeping it in? Because I've heard I'm okay with it as written, and then I've heard use the language of the statute.
I think we've heard more towards the side of keeping it as it's written.
Right.
No.
That's what I meant.
Written
Yeah.
here. As written on
Yeah.
the screen, what you're seeing
Yes.
right now.
Right.
Okay.
As written on the
Yes.
screen. Yeah.
So 2 people.
Majority.
I need a majority. Kat, Mark, Sarah.
This is committee member
Myers.
Wickenhagen. Go ahead, Mark.
Yeah, committee member Myers. I'm fine with it, leaving it as is right there on the screen.
Committee member Wickenhagen, just and able to get this move forward. I'm okay with what it says on screen. Thanks.
Committee member Hammond, I'm okay with what it says on screen as well.
And I'll give it back to you, Chair Anderson, for a motion.
I do have one more, sorry, this committee member Anderson, I do have one more question since we're dealing with this particular continuation of therapy. You're just showing us the cover page. But I was kind of looking over this protocol recently for teaching purposes, actually, and noticed that on the third page, when it goes into the treatment assessment and treatment care pathway, it only has a title that talks about emergency refills of insulin or insulin-related devices. So I'm curious whether or not we could change the title of that.
Yes. I see that here.
Yeah.
Okay, yeah, I can make a
as far
note.
as I can, yeah, as far as I can tell, that whole page is not just for insulin, it's for
Correct.
all the continuation of therapy. So I was hoping we could maybe change the title of that particular page. So it just says continuation of therapy, assessment and treatment care pathway. Because I think even on this cover page, it says that's what that particular part of the protocol is called. But then when you get there, that's not what the title says.
Good catch. We will fix that on all the supporting documents to make sure it matches what you see here.
Thank you so much. All right, I think that was my only other discussion point. Are there other discussion points from the group?
None from me. Great catch, Lorinda. Thank you.
All right, I have too many PDFs open. Okay. All right, so it looks like we all have a bit of a consensus now. So is there a motion to move to recommend the continuation of therapy statewide drug therapy management protocol version 5 of 2024 as revised today to the Oregon Board of Pharmacy for review?
This is committee member Gibler, so moved.
Do I have a second?
This is committee member Hammond. I second.
Thank you. So this committee member Anderson, I approve. Committee member Gibler?
Aye.
Committee member Hammond?
Aye.
Committee member Myers?
Aye.
And committee member Wickenhagen?
Aye.
Thank you. This motion passes. And we will now turn the time back over for the VVC protocol.
All right, this is mailing A2 for those on the phone. I've been reminded to say this.
Oh, sorry.
So, it's my fault. I think I'm supposed to say it. So next up, we're going to talk about what is currently called the vulvovaginal candidiasis VVC protocol. The only change to all these documents is to change the name to vaginal itching. This committee has previously discussed this protocol, also in light of previous conversations that we had, like, remember about the shingles protocol, that a pharmacist can't do diagnosis. And so the title of this makes it sound like we have a diagnosis of VVC, but the protocol itself, like the body of it, is really about a person that has vaginal itching and its symptom management. So this is just a title change to take away any misconception that this is the pharmacist diagnosing somebody with VVC. They're obviously not doing a smear and those sorts of things. They're just helping a patient who complains of vaginal itching using the protocol. So I can open each document, but that is like the only change on each of the documents. It's just to change the name. So I'll give it back to you, Committee Chair Anderson, for discussion.
Thanks. This is committee member Anderson. Any discussion points from anyone in the group?
None from me. This is committee member Gibler.
I did forget that I removed the verified DOB with valid photo ID on the template, just to be consistent with, we've been removing that from the protocols as we've been going through.
This is committee member Wickenhagen. I completely agree with the change, and I think this is glorious for patients.
All right, this is Committee Member Anderson. Do I have a motion to move to recommend the vaginal itching statewide drug therapy management protocol version 5 of 2024 as revised today to the Oregon Board of Pharmacy for review?
I'm sorry, I apologize. This is Committee Member Myers. We're zipping through all that quickly. This includes oral fluconazole. I'm a little confused because I thought this included oral fluconazole, which is by prescription only, yes?
Yep,
Yes.
that is true.
So we're not making a diagnosis, but we're just giving out oral fluconazole for vaginal itching?
That would sound correct, yes.
Staff Member Davis, it's a little more nuanced than that. There's an assessment treatment care pathway. And so there's only certain situations, like the patient answers yes to certain questions, they're kicked out from being able to be prescribed this. So it's the pharmacist isn't making like a judgment call, they're following this algorithm that the committee has approved.
This is Committee Member Wickenhagen, and this is already in effect. We're just changing the name, yes?
Correct. It has been in effect for a number of years.
Yeah, thank you.
Okay, sorry, the nuances are tying my brain in knots, so.
Yeah, this Committee Member Anderson, I completely agree. The diagnosis thing, it'll be nice to maybe get some clarification on that.
I have no, sorry, Committee Member Myers, I have no objection. I was just trying to catch up.
No worries. Are there any other questions or discussion points others on the committee would like to ask or talk about? Okay, I'm not seeing anybody jump off mute or anything. So is there a motion to move to recommend the vaginal itching statewide drug therapy management protocol version 5 of 2024 as revised today to the Oregon Board of Pharmacy for review?
Committee Member Gibler, so moved.
Thank you. Do I have a second?
Committee Member Wickenhagen seconds.
Thank you. So we'll go through the roll call. This Committee Member Anderson, I approve. Committee Member Gibler.
Aye.
Committee Member Hammond.
I approve.
Committee Member Myers.
Aye.
Committee Member Wickenhagen.
Aye.
Great, this motion passes. All right, next committee protocol development for the SARS-CoV-2 antiviral 2024 based on SB 1506 number B. Is that correct?
Yes, thank you for doing that. All right, hold on. Staff Member Melvin's pulling up the presentation. I was just going to speak to this a little bit. So, as we just mentioned, 2024 Senate Bill 1506, I've kind of pasted sections of it. So section 4 is really the meat of it, that it allows a pharmacist to test for COVID and prescribe, dispense, and administer treatment, including drug therapy for COVID. And then it has the parameters of what a pharmacist may use, a screening procedure, a test. It guides clinical decision-making, talks about CLIA, waive test, and then is approved by the board by rule for use under this section. So we have to have a rule that authorizes the pharmacist to prescribe this. It allows the pharmacist to delegate to a pharmacy technician or an intern the administrative and technical task of performing what's described in section 2 of the subsection, which is the test, the screening procedure and test, and then the board can adopt rules. And then in section 6, it updates the practice of pharmacy definition and ORS 689005 by adding paren P, which I can't see now because it did the little Teams thing, but for the testing of severe acute respiratory syndrome coronavirus and the prescribing, dispensing, administering. So it adds it to the practice of pharmacy. A pharmacist can now do this. And then it gives some specific delegated authority to technicians and interns that the pharmacist can delegate. So with that, I just wanted to do kind of a quick recap on the next slide of like, some of you have seen this protocol before, and that's fine. Some of you have not, and you're probably like, why did we get a red line version of something? I don't see this protocol. I've never seen it. Well, here's kind of the history. Back in December 2021, we were right in the heat of COVID. The FDA did issue the emergency use authorization for Paxlovid specifically, which is what our protocol has contemplated previously and currently. In October 2022, the board adopted a temporary rule to allow pharmacists to use a COVID-19 antiviral protocol. And they also, temporary rules are only good for 180 days. So then they also sent it for permanent adoption and permanently adopted it in December of 2022. And I put an effective date of 2/1/2023. That was for a number of reasons, because we were rewriting the rules and moving things around and shifting. But that temporary adoption was still good, you know, all the way through 2/1/2023. So people could use the protocol, and then they had the permanent protocol. And then on the same day that the permanent rule became effective, the FDA revised the EUA for Paxlovid to require a diagnosis to prescribe it, which then put us back in a weird position, because pharmacists in the practice of pharmacy it does not include diagnosis as part of the practice of pharmacy. So the board meeting was the following week. The board temporarily repealed that COVID-19 antiviral protocol. And then again, that temporary repeal is good for 180 days. So in alignment with our normal rulemaking process is that it did the permanent repeal in June of 2023. And then we sat and we waited, and there was a legislative session. And some, you know, proponents of bringing this back, recognizing that pharmacists could still do COVID-19 protocol, not our protocol, could still prescribe for COVID-19 under the PrEP Act. The PrEP Act for this, I think it sunsets a little earlier. I don't think it's December. It might be October 31st. I think it's sometime, you know, at the end of the year. Pharmacists, even though our protocol was gone, and our protocol was kind of meant to like make a similar process, so pharmacists who are familiar with the protocols could use this, they could still prescribe under the PrEP Act. But with the PrEP Act expiring coming up later in the year, we got a new Senate bill that becomes effective in June, becomes operative October 1. And then it actually has a sunset clause on it. So it's only good through June 30th, 2026. My understanding of the reason for the sunset is that the legislators were like, yes, we need a temporary fix. So we're going to get this into law, and then we're going to rediscuss it in the upcoming legislative session. So my understanding is there'll be more to come on this. And then to know, go back. One other piece of this is, as you are probably aware, if you follow COVID at all, the EUA labeled Paxlovid was deauthorized by the FDA effective March 8th of 2024. So, you know, it was a good time. This is all good timing. We no longer have EUA labeled product out there. And with an EUA, you have to prescribe exactly according to the EUA, because it's not actually an FDA approved drug. Now we have a fully FDA approved drug on the market. There's no EUA product out there. And so we are updating what used to be the COVID protocol. We're now calling it the SARS-CoV-2 antiviral protocol. And that's what you see the track changes against, is the old protocol that was repealed in February of 2023.
Jennifer, this is Committee Member Gibler. I think what you mostly said is true, but we do have molnupiravir, which is still, I believe, under EUA, but is specified within the labeling that pharmacists cannot prescribe that drug.
Thank you for the clarification. I was really only speaking to like our protocol and what we have.
Yes, I know. I just wanted to clarify that for everyone, though.
Yep. So I'm going to share my screen. And just a little history on this. We did have, back when this was originally written, committee member Gibbler was not on the committee at the time. And he was one of the subject matter experts, along with two physicians that were working with OHA during the pandemic. And so he kindly offered to work with me to revise the old protocol to match the new bill language. But so that he doesn't have to deal with any potential inferred conflict of interest, I'm going to present the changes should we work together to make them in accordance with Senate Bill 1506. So you'll see throughout just renaming the protocol, the standardized, antiviral, the intake form didn't change. I just got rid of the duplicative language, same thing. Not making anything required that wasn't required previously, just updating. The pharmacist must be familiar with how to access patient laboratory data to assess renal and hepatic function. Must review the resources that are available for healthcare providers. And then we updated the trainings. The committee had previously said this is only recommended, it is not a requirement. And made updates to what is currently available, as some of the CDC webinar stuff from like 2020 was outdated and no longer applicable. So we gave it new links. And it looks more like this when you look at a simple, pretty markup. But those were the changes to the cover page. Any questions? Open the second document. This is the patient intake form. View, markup. Why it keeps showing me formatting changes. So the only thing, well, there's a couple of things that changed on this. So we removed question 1. Have you had a positive SARS-CoV-2 antigen test within the past 5 days? And then if no, would you like to be tested at the pharmacy today? The language in the bill requires the pharmacist to test in order to treat or prescribe the antiviral. So they can't be using a patient's self-test at home. It has to be testing and prescribing in combination. So that's why number 1 was removed. Andrew did a cleanup on kind of what the different conditions were that put someone at risk potentially for contracting COVID. We did have a question that we didn't resolve prior because we wanted to talk with the committee about it. So do we want to include risk factors that are suggestive of higher risk, which is overweight, not just obesity, sickle cell disease, and substance use disorders? And so those, I think right now have been struck, the ones that were there, but could be added back in. And then just a note that thalassemia has mixed evidence on whether it may be a risk factor. So we want to go with the clear items that are definitely risk factors, or also include risk factors that are suggestive of higher risk. And I'm going to give that back to Committee Chair Anderson to facilitate discussion on this or anything else I've gone over so far.
Thanks. This committee member Anderson. I personally like the idea of only sticking with the things that have clear risks. But what do others think?
This is committee member Wickenhagen. That seems very reasonable.
This is committee member Gibbler. I think without the evidence that they are high risk, without decent evidence that those really are risk factors, combined with the extremely high cost of this medication and the fact that the medication cannot prevent the hospitalizations and deaths that it did in the original phase 3 studies, because of the evolution of the virus and our own immunity to the virus has evolved so much that that we probably should just stick with patients that really could potentially benefit, which is the ones that have evidence of being a real risk factor.
Committee Member Myers, I think that was well said.
Committee Member Anderson, I agree. I was actually going to say the same thing. Thanks, Committee Member Gibler.
Staff Member Davis, I actually have one question for Committee Member Gibler. So I saw substance use disorder here. Did you intend to strike the problematic drug or alcohol use, or is that separate? You know what I mean? Because you struck all the other ones, but I don't know if that is different than substance use disorder.
The substance use disorder doesn't mean that they're abusing. It's a diagnosis. They're in treatment, so they're different. And I would defer to others that may have expertise more. But the CDC still lists problematic current drug and alcohol use as a risk factor.
Okay.
They don't have the nutrition. They don't probably have the immunity. So there's a lot of other problems that someone with opioid use disorder may not have.
That makes sense to me. Thank you for the clarification. And hold on, go to all markup so we can see the other changes. So the only other change was adding this first number up here to be completed by the pharmacist, because the pharmacist now needs to do the test or delegate to a technician or intern to perform the test. And so that would need to be, the information would need to be recorded concerning the test and its results.
This Committee Member Anderson, is there a place that specifically says that those can be done by somebody else? Because the whole thing is titled to be completed by pharmacists, which makes me think only a pharmacist could do the test, but we know per the statute that can be done by other, an intern or a tech.
So yes, in the assessment and treatment care pathway, which we'll go over next, it directly addresses that. This is just for documentation. Would you want me to add that a technician or intern may complete Paren 1?
I guess I would feel like if the technician was the one, or an intern was the one that did the test itself, that I would kind of want them to sign off on it, in fact.
Yeah, this Committee Member Gibler, I agree with that. This is all objective information, and so they would very much be able to fill in this information. Otherwise, they're setting all this in front of the pharmacists and having them look and fill it out, and so it can probably be a little messy and I don't know, complicated.
So I've added language that says if intern or pharmacy technician perform the test, they may fill in number 1.
Thank you. I think that would satisfy it.
Yeah, that works. Thank you.
Oh, and then down here at the bottom, removal of the requirement to give the EUA fact sheet, because that no longer exists, because it's not an EUA product anymore. There's no requirement to give any printed paperwork. Give me just a second, I'll open the next document.
This is Staff Member Melvin. Committee Member Hammond, do you need to leave the meeting right now? This is a good window. If so, you would just need to state it for the record.
Yes, this is Committee Member Hammond. I do need to leave the meeting. Thank you.
Thank you.
Okay, so next is the standardized assessment and treatment care pathway. And this is where you see like the majority of the changes to be consistent with the law. So in paren 1B, the EUA permitted, well, actually 1A, permitted it to be provided to patients 12 to 18. And when we remove the EUA, this now aligns the protocol with the FDA approved indications, which is 18 and above. So that's why the age change. The weight that was removed because I don't know.
It's not in the,
It's not.
we're limiting it to adults and there's nothing in the labeling that has anything to do with weight.
Okay.
That's for the kiddos.
In paren 2, it authorizes the treatment screening. So a positive CLIA waived, EUA authorized, FDA cleared or FDA approved SARS-CoV molecular or antigen test completed by the pharmacist or intern, certified organ pharmacy technician or pharmacy technician. So it's clearing up that the law says a pharmacist may use a CLIA waive test. It doesn't require that it be a CLIA waive test, which is a good thing because a lot of these COVID tests are not CLIA waived yet. It's a process. It takes months and years. There's many different parts to the process. So this protocol would permit the pharmacist to use pretty much any COVID test on the market that meets one of these. It would cover most on the market.
This is Committee Member Gibler. Jen, I'm Staff Member Davis. Do you know if, can you explain what FDA cleared means? I'm not.
That's going to really, I don't know, don't remember that off the top of my head.
Is that an actual phrase or an actual category? Okay.
You can find information about each home or lab test the FDA has approved or cleared by searching the database. And I had gone into their database. So this is more about, I think it's more based on the home testing when you get into FDA cleared devices. I'm not the expert on FDA, but there are FDA cleared COVID tests.
Okay. And just grammatic, I mean, you can just hyphenate FDA cleared and FDA approved as you did with CLIA waived and EUA authorized.
Okay. So it authorizes the pharmacist to use pretty much any test that's available. It removes this note about the positive patient self-testing because that's no longer permitted. The law requires the pharmacist to do the testing. And then here's the note I was referring to earlier, Committee Chair Anderson, about a pharmacist may delegate to an intern, COPT or PT, to do the administrative and technical task of performing the test. And then in section 3, that the patient attests to at least one risk factor in paren 3, and this was just a note to if we needed to add that. So we've already resolved that conversation. And then makes the language consistent with what we just discussed, only talk to obesity and only have the BMI for obesity here instead of including overweight. This whole section is about placing an individual at risk to progression to COVID-19, and language updates and changes were suggested to make the language shorter, but to also just be up to date with the current language being used. And then removing references to the EUA. Down in step 4 for the renal function assessment and screen. If yes to step 4A, if patient's currently on dialysis, is reported on the self-screening form. Advise the patient seek care from a medical provider for further evaluation. It used to say refer as outlined in the EUA, and then updated the language again instead of saying refer to the EUA. Same thing as section 5. Section 6. Section 7. So just kind of cleaning this up and not being as specific. So after review of medications, the pharmacist identified potential drug interactions, serious drug interactions with Paxlovid using the product labeling or another drug interaction tool. And so not having the specificity about which drug interaction tool. We know that these are being constantly updated with Paxlovid as new drug interactions are found. Same language changes at the bottom instead of referring to the EUA. The EUA required that you document the patient education. There's no need to have an additional requirement for this since it's no longer required. Pharmacists would still have to document patient counseling according to our patient counseling rule in 855-115-0145. Retaining the ability to prescribe, notifying the primary care provider within 5 days of receipt of the therapy, and then removing the requirement to report adverse reactions to like MedWatch or this FDA form 3500 is the MedWatch equivalent for an EUA authorized product. So since it's no longer EUA, we don't require pharmacists to report to MedWatch for any other drugs that they dispense or prescribe in our rules. And then removing language about the EUA. Any questions from the committee on the changes to the assessment and treatment care pathway?
This is Committee Member Anderson. I don't have any questions.
Okay. Give me just a second. I'll open the next document. Changing the title, removing the valid photo ID, just a little like grammatical fixing of things, but nothing major there. Any questions from the committee? And then the last document is the provider fax. Like my computer is now defaulting to showing formatting. So just making consistent language. Again, the same kind of grammatical edits we made before, and removing that the patient was provided with the EUA fact sheet. But they are still informed that an office visit is recommended after finishing the course of treatment. And if they have further questions, to contact the prescribing pharmacy rather than contacting Pfizer's medical department since it's no longer on EUA. And then just a statement about this prescription being issued pursuant to our rules. Any questions from the committee on this?
This is Committee Member Wickenhagen. No questions.
That is all the documents in the protocol, so I'll hand it back to you, Committee Chair Anderson.
Oh, and this is Staff Member Melvin. Committee Member Anderson, this motion, you guys will need to say revised because she did amend it in real time.
This is Committee Member Anderson. Thanks. All right. So is there a motion to move to recommend the SARS-CoV-2 antiviral statewide drug therapy management protocol version 5/2024 as revised today to the Oregon Board of Pharmacy for review?
This is Committee Member Wickenhagen. I make that motion.
Thank you. Do I have a second?
Member Kibler, I second.
Great. I'll go through the roll. So this Committee Member Anderson, I approve. Committee Member Gibler,
Aye.
Committee Member Myers,
Aye.
and Committee Member Wickenhagen.
Aye.
Great, this motion passes. All right, the last item on our agenda is if there is public comment. So we will now take public comment. Please note that the committee.
This is Staff Member Melvin. Sorry, nobody signed up to provide public comment today.
Oh, all right, great. Thank you. I'll stop going through the script then.
Give us just a moment.
It's missing.
We are missing a section. Give me just a moment and I will pull it up. There is one more discussion item that is on our public agenda that didn't make it onto this. Give me just a moment. All right.
You just followed 9:15.
I don't know, because I'm driving too fast. Give me just a second. And you're ready, right?
Yeah.
You have something. Let me just. There's a mailing, correct?
Don't think there's a mailing.
Just a discussion.
Is it this formulary discussion?
Yes.
Yeah.
Sorry about that. Yes, it's just formulary.
Yeah, there's not a mailing, but
Yeah.
there's a discussion I need to
I just missed a
facilitate
bullet.
you guys. So
Oh,
Staff Member
okay.
Melvin's gonna pull up the slide deck that I've been sharing. And the next slide. So give her just a second to get it up here for you.
And we'll add this to the meeting summary.
Yeah, and this will be in the meeting summary, the slide deck, so people can see it. Next slide. Oh, yeah, so here's our statute, ORS 689-645, that talks about the formulary. And so in accordance with the rules adopted by the State Board of Pharmacy, so we have to adopt rules, a pharmacist may prescribe and dispense a drug or device included on the formulary established under subsection 6, which I have that here on the slide, if the prescription and dispensation is pursuant to a diagnosis by a healthcare practitioner who has prescriptive authority and is qualified to make the diagnosis. And then in parenthesis 6A, it says the board shall establish by rule a formulary of drugs and devices recommended by the committee that a pharmacist may prescribe and dispense to a patient pursuant to a diagnosis by a healthcare practitioner as prescription authority and who is qualified to make the diagnosis. And then paren B goes through the list of the formulary, can include post-diagnostic drugs and devices, and has a list of different items that could potentially be included. So what we wanted to do today was just have a conversation with the formulary committee, and you can go to the next slide, about are there any potential additions you would like to see to the formulary that agency staff could be working on, trying to find, trying to work up for you. So like things to think about. These don't specifically need to be answered, but like, so we have drugs that are authorized by statute that a pharmacist can prescribe. Emergency refills of insulin is an example, but it also has parameters in the law. But are there drugs authorized by statute that you'd like to see considered for placement on the formulary? Are there drugs that we currently have authorized by protocol to prescribe that you would like to see considered for placement on the formulary? And then in general, are there just drugs that are post-diagnostic that should be considered for placement on the formulary? So we just wanted to have kind of a brainstorming session, get your thoughts and opinions. Some we might be able to do, some we might not, depending on the statutory authority and the limitations that are in statutes. But just wanted to hand that back over to you, Chair Anderson, to facilitate a discussion with the committee members.
Great, that's great. Thank you. This Committee Member Anderson. I'll start off the discussion by throwing out my personal opinion, I guess. I would like to see more drugs added to this. And at the very least, the ones that are mentioned in statute that include albuterol inhalers and epinephrine pens and the emergency insulin. What are others' thoughts on these.
This is Committee Member Gibler. In addition to what Committee Member Anderson brought up, I would like to see protocols for all the devices and supplies on the formulary that simply clarify that the patient attests that they have a diagnosis that requires that supply or device. So pharmacists don't have to guess what diagnosis they need.
This is Committee Member Anderson. Are you suggesting adding those into protocols so that there is some sort of documentation that the patient has a
so
diagnosis?
very similar to our naloxone protocol that we approved last time. Do I want an ostomy supply? Yes. Do I have a diagnosis that requires ostomy supplies? Yes. Done.
Oh, I like it.
Something like that. If that goes around this whole issue that we were discussing earlier around requiring a diagnosis and explaining to the Board of Pharmacy what they use to verify a diagnosis, and is that good enough? And let's have the Board of Pharmacy review this, and is there disciplinary action or not? I think it scares pharmacists, and they don't want it. I'm afraid they aren't using the formulary as it's intended, because that might be a question. I don't know. I'm not a practicing pharmacist. I'm just guessing. But that would be my personal opinion as a member of this group.
Yeah.
Ways to facilitate it so we can help patients get the access to the supplies that they need and what I think the legislators intended.
This is Committee Member Anderson. I'm also wondering if maybe the converse might be true, where we include something on the formulary where the pharmacist would have a section that they fill out to verify or say that they verify that the patient has a diagnosis prior to it. Kind of like having something that we see in the protocols, but that you would just include on the formulary first, sort of as a description to the formulary.
I see. Yeah, that would work too, I think.
Committee Member Myers, did you have a thought?
No, sorry.
Oh, sorry. I just saw that you were off mute, so I thought maybe.
This is Committee Member Wickenhagen. Anything that pharmacists need that are clearly in the benefit of a patient, I would be in supportive of. So, yes.
Awesome. I like that idea where on the actual document that you pull up for the formulary on the website, I like the idea of including something that just states that the pharmacist has verified that the patient has a diagnosis to receive the following, and then have the list after that. And then we could include drugs into that, but then also obviously keep what's already there with the devices.
And if they have to write down the prescriber's name, I mean, that's pretty straightforward. We can do that because it has to come from a prescriber. So, I think the patients would know who their doctor is.
Yeah, this Committee Member Anderson, do we want to have anything in there that says, that the patient gave us the doctor's name? Or do we want to say that the pharmacist called the office to verify that they had that diagnosis, or that they accessed the EMR? Because and I'm just saying that for the few pharmacies out there that have access to EMRs.
This is Committee Member Wickenhagen. Can you also verify that by just a previous prescription if they have a prescription bottle?
Yeah, like if it was for the emergency insulin, and that kind of goes back to the whole discussion about the
Yeah, it
emergency
does.
insulin. Yeah.
Okay, thank you.
And if we're going to go down that route, I think can we clarify in writing what makes for a qualified diagnosis under the statute? You know, patient
Yeah.
attestation, previous refills of the medication that implies they have diabetes, access to the EHR with confirmed diagnosis code, you know, calling a provider, all of the above, any of the above. Is there, any way to kind of make it clear to pharmacists what works, what constitutes confirmation of a diagnosis.
Yeah, this committee member Anderson, I think that would be fine. Obviously, we're just making this recommendation over to the board, and then the board would have to
Yeah.
also agree to it. So I think I like the idea of saying these are our recommendations for how pharmacists are going to verify a previous diagnosis.
Yes. Oh, I closed it at the end.
So we've been taking notes. Very good discussion, very helpful. It kind of seems like the sticking point has been that piece of requiring a diagnosis and how that can be documented or what is acceptable for that, making pharmacists feel more comfortable with using the formulary. I didn't hear a lot of like specific drugs that you would like to see brought over either from statute or from current protocols. So for us to start working up, I heard a couple, so I can start working on those to try to see. Is there any other specific suggestions? Do you have a mind? And you're welcome to think about this and we can have another conversation.
This is
In
Committee
August.
Member Wickenhagen. I mean, do we have any data to support that? I mean, is it possible to do a survey of pharmacists asking what might be needed? I mean, it's kind of a stab in the dark for me.
That is an idea, take under consideration and talk with.
This
Board with
committee
about it.
member, this committee member Anderson, I think we for sure can stick with, or at least start with the ones that have been mentioned in statute. So for sure those three. But I agree that they're like we haven't really had much time to think through other ideas. Have there ever been, yeah, there you go. So smoking cessation aids, we could add nicotine replacement therapy easily to that. I don't know that we would want to get into the bupropion and varenicline like the protocol does, because that one has a little bit more parameters.
Can someone explain the discharge meds for transitions of care? Because I mean, that's interesting. There's a lot to unpack in that, in just that. And I don't know if there's additional thoughts on that. Certainly I think, yeah, I'm not sure what it means. Like we've got a prescriber that's prescribing a discharge. I have a million questions just looking at that. I don't know.
This committee member Myers, I mean, would that be a scenario where a patient walks out with a discharge list of medications that they were handed, but then they were failed to be sent over by the hospital? I see that not infrequently. So they have this list that is their discharge medication as they're coming out of the hospital from being hospitalized. And yet one of the prescriptions didn't get sent over, or they didn't get a handwritten, but they've got a list that says they're supposed to be receiving this.
Yeah.
Interesting.
To Staff Member Davis, just based on listening to the legislative testimony, I concur with you that I wish more had been said about this list, because there is not much history on what the people who were proponents of the bill or the legislators intended by this list.
Yeah, I mean, like it could be in controlled substances, which we can't prescribe. Pharmacists can't prescribe. It could be the remaining day supply of their antibiotic, which if the physician forgets to prescribe is very much important, but usually that could be clarified just by calling the hospitalist who discharged the patient, getting that. I think I don't want to touch it, is what, because I don't have any ideas what to do with it yet.
Yeah, this committee member Anderson, I'm not sure what we do with the rapid strep tests either. I mean, I think a lot of the rest of this list could easily be added, so we already have the diabetic testing supplies included. So the new things would be, we also have the spacers too. So I think the new things that we could easily add from this piece of statute was the emergency refills of insulin, the albuterol inhalers, epinephrine auto-injectors, and maybe nicotine replacement therapy. So those would be
limiting only to NRT, Lorinda, or?
Well, and that's what I was saying. I feel like, I mean, I suppose we could add the bupropion and the varenicline as it's mentioned in the protocol. But then that would, I don't know, that kind of goes back to the previous point that Staff Member Davis had with, you know, do we want to start bringing over all the meds from protocols?
So Staff Member Davis, I would just speaking to that specific example of bupropion and varenicline, if you were to add bupropion to the formulary, a pharmacist could prescribe it for anything. It's not limiting it to nicotine replacement therapy. And we all know that bupropion is used much in mental health, not just nicotine replacement therapy. So something to consider, you know, in terms of patient safety, collaborating with other healthcare providers. Once a drug is on that formulary, there is no limitation as long as the patient has a diagnosis, and we can work on clarifying what that diagnosis piece is, but there's no further limits.
Okay, thank you for clarifying that.
And this committee has discussed that in the past, and where some original concepts that were like really broad, like all antihypertensives. And the committee said, no, it needs to be drug by drug. And, you know, we have concerns about just putting this on a formulary, because then if I have a diagnosis of hypertension and I walk into the pharmacy, the pharmacist prescribes atenolol but doesn't tell my provider, and then, you know, things happen. So there's.
Are there, which NRT products are OTC? The patches, right? Are there others?
Patches, gum, lozenges.
Almost all of them, yeah.
Yeah.
I think there's only one that is not, which is like the nasal spray, I believe.
Yeah, that's right.
Yeah.
So that comes with all the patient, you know, education on the packaging. It'd be something we could add to the formulary easily enough.
Yeah, I would agree. I think you could easily put nicotine replacement therapy.
And can you clarify again with Opal, the OTC oral contraceptive, could that be added as a standalone on the formulary? Or is that?
It could, but I think it goes back to the whole they would have to have some kind of diagnosis for it, which unfortunately may make it a lot more limited. And like, what diagnosis would you use for that?
So preventative services require a diagnosis.
Yeah.
That's what we keep coming back to in this, it doesn't say non-diagnostic things, like it doesn't address that. It requires a diagnosis. I also just want to mention with OPIL, you still have ORS 689, 689 out there. So even if you were to add it to the formulary, there's things the pharmacist must still do, like training, using a self-screening assessment tool, all those things that, and we have to use a committee and we have to adopt rules and consultation, around that. So there's a little bit. I mean, yes, could it be put on the formulary? Sure, but there's not a diagnosis, and we have this other statute that has additional requirements beyond just pharmacists can prescribe. But we will add it to the list of items you discussed for sure.
I mean, all these, yeah, I still get back to this whole diagnosis thing, like just for smoking cessation aids. I don't know, like, how do you get a diagnosis for any of it? And that needs to be clarified somehow.
This is committee member Wickening, and I mean, sort of verbiage and something that I hear pharmacists say all the time is you need to be counseled. And I know counseling is billable. And I know sometimes from a preventative standpoint, that's how providers will bill for time or bill like a Z code. So just throwing that out there.
Yep. All right, Committee Chair Anderson, no additional hands or comments. I think we're ready to conclude.
Okay. This committee member Anderson, so do we want to make some kind of item that will move forward later to add these and include the information about, so like, as in having another agenda item on next meeting, or how is that going to work? Like, is this, so this, I like this discussion. I think we all like the idea of adding stuff to the formulary. Do we want to try and do that during this meeting, or do we want to just mull it over?
Staff Member Davis, so what my plan was to take this conversation back today, and then we need to run it through our internal, like, fact checking, making sure everything would work, and then bring back some options, some language for you for the August meeting, then to potentially, then recommend to the board. But I think doing something without a plan and without having done any research or background and double checking that we're not mismatching a statute or, stepping outside of what we can do would not be a good idea today. But
no, that would be perfect.
We can bring it back for August. Yeah,
please, please review everything, what our ideas, and see what can happen with the current statutes, and bring some ideas to us. I think just the formulary in general it doesn't have a lot of weight behind it just because of this diagnosis language. It's very difficult unless others are seeing pharmacists use it successfully. I'd like you to explore that, and that would help give me ideas of what to add to it once that's clarified.
Well, in this committee member Anderson, I do feel like people do use the devices on there. So I do like the idea of trying to add more to it, but and like we already just added CGMs on one of our last meetings. But yeah, I just wanted to know what the plan was moving forward. So thank you. Appreciate that clarification.
So
All
are we
right.
ready to adjourn?
Yes, I was just about to say that. So I think that brings us back to adjourning. So hold on. All right. Do I have a motion to adjourn the meeting at 12:35 p.m.?
This is committee member Wickenhagen, so moved.
Thank you. Do I have a second?
Committee member Gibler, second.
Great, thank you. This committee member Anderson, I agree. Committee member Gibler,
Aye.
committee member Myers,
Aye.
and committee member Wickenhagen.
Aye.
Great, this motion passes and we are adjourned. Thank you, everybody.
Thank you.
Thanks,
Thank
everyone.
Thank you.